spending $100 per capita per annum on the health of an average Nigerian, then we need help from everywhere that we could get help from. Okay? And that is why today we must think outside of the cap. Yes, as doctors, we are the leader of the health team. But as doctors, we know we don't have all the resources. So we must embrace partnership so that we bring the results, the kind of result that we desire. How do we envision partnership in the context of the health sector? How do we envision partnership? Partnership, we must know, are not just about cooperation. So it is not when we go on podium, I will say we are collaborating with this. We are cooperating with the nurses. We are cooperating with the banks. It's not enough. So partnership is not just about cooperation. It is about synergy, where we combine efforts to achieve far more than an individual can achieve. In the health system, this synergy can mean we will save lives together so that nobody thinks it's the only, is a special one. We save lives together. We empower communities together, and we build a healthier nation together. What are the key health system partners that we need to identify? Because for us to move forward, we need to map the partners that we as NMA or as individual physicians or as team lead within our sector, as commissioners, in our spaces, as ministers, must start engaging. Of course, government is the major sector because it's the driver of all of the sectors in Nigeria at both federal, at federal, state, and Nigerian level. Development partners are critical partners. I'll give you examples of collaborations that have resulted in impact in Nigeria. And now we can leverage that lesson to build the newest system that we all desire. If you look at development partners, they are categorized as multilaterals, the UN agencies, the World Bank, the Global Fund, the bilateral organization. You remember the USAID that has been scrapped by the US president. Of course, that's been replaced by Department of State. They now carry out the work of the USAID in Nigeria. US CDC is still there as a bilateral entity. We have UKFCDO and many others, JICA, Japan, Canadian organizations. We have different foundations. We have Bill and Melinda Gates Foundation, the Clinton Health Access Initiative, MTN Foundation and co, philanthropists. You know, they have several philanthropists that are doing great, even in Nigeria, Danjuma, Dangote and co. We have private sector players, providers on one leg, health product manufacturers, other hand, HMOs are private sector entities who have roles to play, and we'll delve into that later. Religious organizations are doing great globally and also in Nigeria. NGOs, communities also play their part. If you give the microphone to my teacher, Professor Akin Oshibogun, he will tell you from now till tomorrow how communities have empowered and collaborated to deliver its services. Social infrastructure, platforms, National Registration Agency, these are potential partners we need to work with, and I'll tell us how and why. Social media platforms, social clubs, and other entities, they are very important in delivering health system. Development committees, association, our CDC, CDAs, we have in various communities. Many of them have built health institutions, health centers within their community and supported government. We have key actors, community gatekeeper, influencers, and co. What are the type of partnership that we could look forward to formulating as we move forward? So I'll just share some type of partnership that are possible within the health sector space. Of course, the commonest that we describe is the PPP, public-private partnership, where you have long-term contracts or concessions, where private sector parties design, build, finance, operate, or manage public infrastructure or services. So that is the commonest approach, the PPP approach. We also have multilateral and global health partnerships, where alliances of UN agencies or bilateral organization donors, NGOs, and industry are created to tackle specific diseases or fill system gaps. And they come in terms of direct funding, finance, and leverage on governance structure, so that your governance expenses becomes reduced. On electronic health records, you can have shared records, you can have referral pathway and payment arrangements in a collaborative manner. Another type of partnership is academic and technical partnership. Academic partnership, technical partnership are collaborations between universities, teaching hospitals, and Ministry of Health or private sector entities, where this partnership provides opportunity for training, research, and guideline development, and allow capacity building, evidence generation, and quality improvement in a way that it bring a win-win arrangement for the partners. The sixth type is a community and civil society partnership that has to deal with the local NGOs, faith groups, community health committees, and so on. We have the market enabler of the finance partnership. We have a lot of people, what we call private capitals. All we have to do is to open up our system and be transparent in our numbers. Private capitals are there looking for area to invest, and we need to look for such opportunities. They provide loans, guarantees, accreditation, and technical assistance, particularly to private providers. And last but not the least, we have result-based and performance partnership, usually led by donor organizations. They want organizations or entities that can show results, and they are ready to pay for the results. I was talking to one of them just yesterday night, Give Well at giving more than $100 million to Nigerians who are able to show results while they provide services. And they are in Abuja, and I'll be talking to them next week. What strategies do we have to unlock partnership potential? What strategies? Like I said, we have acquired the critical knowledge of syndromes, of clinical conditions, of pathology and pharmacology, but we must begin to learn and master the act of partnership and engagement. And so what strategies do we need? We need to begin to align our goal so we do not personalize health system goals. When you personalize health system goals, then you don't key into the goals of other people who have resources to share with you. We must begin to align health system goals with the goals and aspirations of other important players within the investment space. Ensure all partners share a common vision, e.g. universal health coverage, and benefit to other people. We need to begin to look at strengths and our weaknesses and learn to leverage on other people's strengths. And look at unique expertise or unique strengths, including funding strength that you don't have, and allow others to bring. We need to start building trust, because transparency and accountability are essential for long-term collaboration. I tell my boss, the former governor of Ogun State, we usually tell us at executive council meeting that 1% of something is better than 100% of nothing. I'll come again, that 1% of something is better than 100% of nothing. So when we build trust, some people will bring big resources to us, and our 5%, 10% share may be better than the 100% of our entire enterprise. And I can share a sample experience with us if time permits. We also must get to a point where at system leaders, at S-level actors, we must begin to show interest in our ability to measure impact. The emotions around we do this, we must be able to show results and justify the resources that have been committed to us. And these are strategies we need to begin to embrace to unlock potential partnership. We must ensure mutual accountability. We must begin to use data to drive our funding need and approach. We must track progress and make sure we are accountable. I'll give examples of partnership for system improvement that has worked within the global space, so that I take this home. First example is the Global Fund for AIDS, TB, malaria. We know Global Fund is a contribution from all countries. Okay, Nigeria contributes about 10, 20, 100 million, $1 million during the replenishment period. But every funding cycle, Nigeria gets about $1.2 billion from Global Fund. Every funding cycle for HIV investment, TB, malaria, and AIDS system. Okay? Another example is Novartis GSK access to medicine initiative, what they call the public-private access model, where you have large pharmaceutical companies that partner with NGO, government, and access platform to donate medicine for low, middle-income countries and strengthen supply chain. There's a new HIV medication that is going to come into use from next year. For instance, the HIV medication is a medication, we call it long-acting antiretroviral medication. Okay, Levanapril for those who know, whatever the name is. Okay, but the initial price is put at about $24,000 per person. Okay, and the way it works is that everybody takes just one injection every 6 months to prevent HIV infection. Rather than using medicine every day. And through global partnership, that $24,000 had been reduced to about $40 per person. And Nigeria will be benefiting from that global initiative from next year. Gavi is another example of global initiative where public-private alliance, including WHO, UNICEF, donor manufacturer, that finance vaccine manufacturing and introduction and market shaping, and they bring it to us at a very low cost in developing economies. Over 1.1 billion children have been immunized through this initiative, and several millions of deaths have been averted. I'll come back home to use examples that are close to us in Nigeria, where partnership have contributed to significant health system progress. I was talking to you that my company, Peloton Global Services, we were funded by the Global Fund to help Nigeria address the number issues. Nigeria became a laughingstock in the global space. Every time we went for international meeting, there are 3-4 figures coming from Nigeria. Everybody will say their own partners, Nigeria government. And sometimes in 2023, they recruited my company, Global Fund, to look at the books of everybody and come to the accurate number. And the new number of 1.67 million Nigerian medication was arrived and agreed and approved instead of the divergent numbers of the past. But what has brought about this level? And Nigeria has achieved most of the 95 objective of the HIV control community. PEPFAR Global Fund collaboration, they work alongside to pool procurement rather than buy drugs separately. These two big bodies who provide almost 93 or 94% of everybody taking HIV medicine in Nigeria with their medication free of charge. Because Nigeria government only pays for about 6-7% of HIV medication. Okay, 93-94% is funded by both Global Fund and PEPFAR. And these two big organizations pull together their resources to negotiate large volume of drug and leverage on economy of scale to bring the cost down so that they can reach many more people in Nigeria. Gates Foundation, Aliko Dangote Foundation, they have targeted support for northern states on the routine immunization strengthening, including cold chain, funding flow, and community engagement. This partnership has helped raise coverage in many of the pilot states supported. The Farmer Access Initiative, the Farmer Access PPP, and next to Finance Pilot, is a support to private operators. They are contracted to run or revitalize primary centers paired with concessional loan and quality improvement, the Safe Care Project. They produce high level utilization and improve maternal and child care in the primary care centers they have invested in. The Shell, NNPC, Total, and other oil majors, they deliver large CSR investment, donating equipment, running high care companies, campaigns, and supporting community insurance scheme in many communities, particularly in their areas of operation. The MTM Foundation, just on Monday, was awarded at the presidency for some of the great work they do through partnership with Private Sector Health Alliance of Nigeria to upgrade primary health care centers, fund outreaches, and improve maternal child indicators through what we can do together initiative. I'll go because of many of our colleagues who are here, who are private providers, who also lead big hospitals, to focus particularly on partnership for service delivery away from the broader system. I've said, and I remember I'm saying this for the often time, I used to run a private hospital in Ijebu, 25-bedded hospital. If I'm given the opportunity to do that again now, I will never do it alone. I'll look for partners, I'll look for colleagues, I'll look for complementary expertise. So that rather than build a 25-bed hospital, we'll build a 1,000-bed hospital from the start. Okay, I'll be able to reach many more people, we'll be able to leverage cost, and then I can make money when I'm even sleeping. Because when others are working, I'm sleeping, I'll have a share, a cut of what they make. So partnership for service delivery. Successful group medical practices built through partnership combine integrated governance, like I said earlier, salaried multi-specialty teams, shared data, IT infrastructure, and aligned financing to deliver better outcome, and scale. What are the key critical success factors for partnership in healthcare delivery service? You must ensure that the governance structure is physician-led. So let us not be misled that physicians are not good managers. Okay, what we have to do is to either, if you don't have the skill, acquire the skill. Management skill is not brought from heaven. Physicians can also acquire the skill. It's unfortunate that management theories are not part of our undergraduate trainings. Okay, and I put to NMA, we must begin to look at advocacy to ensure that the curriculum for medical training begins to change to make sure that they prepare an average doctor for leadership responsibility immediately post-qualification. So we must have physician-led governance with verifiable project management skills. We must have a situation where we align the clinical leadership and operational process. We call it including assembly line flow. I'll discuss that later, so that we can take service to scale. Seeing 5-10 people by a specialist, it's a bad use of skill, right? And specialization. Integrated payment models. We must allow all form of payment. All form of payment. Not that if you don't deposit, you cannot take service. We must share technology. It is pointless everybody buying their technology that are not speaking to each other. We must have coordinated care across settings and specialty. Like I've said earlier, salaried and blended compensation. It reduces volume-driven care. You don't have to see everybody to benefit from the system. And population health incentives. We must have a system that incentivize health services for the poorer part of the population. I'll just give examples of partnership model in service delivery at the global stage. Example, there are four models that I have listed there. There are many more other models that I have not written, but there are 4 major models that I've listed there. The first model is integrated group practice. Integrated group practice, I think I've dwelled on that. Example is Cleveland Clinic, and of course a large salary group practice organized into organ or disease-based institutes that pool specialties and standardized care pathway. The second model is what we call integrated payer-provider partnership. And a good example of that is Kaiser Permanente. Kaiser Permanente is a group practice in California, USA. It's a combined non-profit health plan plus multi-specialty medical group, including hospital delivery, prepaid, coordinated care, and so on and so forth. It aligns incentives, enterprise, health information record, and then population health programs. The third model is a physician-led multi-specialty group practice. Example is Mayo Clinic. And the last but not the least is the high-volume cross-subsidized partnership. The example there is Aramvid High Care System of India. So I'll go into comparing two of these models. Okay, the first is looking at Aramvid High Care System and Kesa Permanente. If you look at the model, the Aramvid in India is high volume social enterprise, high volume social enterprise hospital. Outreaches, they also combine manufacturing. So one entity, they manufacture the product they use, they train the people, they have training opportunity, they brought teachers into the space, they have manufacturing, they manufacture their product. And rather than sitting down to wait for patients, they also do community approaches to recruit patients into their system. For Kesa Permanente and integrated plan, multidisciplinary group, or they are a group of hospitals. In governance, the Aramvid High Care System is a mission-driven non-profit network with centralized clinical protocol. They also ensure, in terms of payment and financing, cross-subsidization, where patients who are able to pay, they fund those who are not able to pay. In terms of scale and focus, Aramvid High Care System have a very high surgical volume, focus on high care, particularly cataract. The other Kesa Permanente is multi-specialty, but most importantly in terms of their strength. Here, as we partner, the partnership may help us understand the concept of operational efficiency. We will adopt task shifting strategies. We will, like I said, emphasize outreaches and ensure that we provide a cost-effective and low-unit services. I have documented that I'm going to share this with NMA, that many of these, we can actually study them, and they are models that are replicable. The Aramvid Eye Care System of India is exactly what Eye Foundation Hospital is doing in Nigeria. Dr. Kule Azan is exactly what it's doing in Nigeria. If you get to Eye Foundation Hospital, you see the setting for the very big men of the society. And you also see setting for people who are able to pay moderate cost. And everybody benefit from the same quality of care. Everybody benefits from the same of care. So I deliberately put this because these models are replicable. They've been done somewhere else. They are not rocket science. NMA physicians, we can lead partnership in this direction and make sure that we give health services that Nigerians truly deserve. For the Aramvid Eye Care, it's a replicable model, high efficiency, community outreaches, in-house manufacturing, like I said, training experts. They collaborated with many institutions, so they training the experts in-house. They also train allied staff, make sure that they do not populate the place with high-skilled people, but people who can task shift within the system, financial sustainability, and they have a social mission. The Kesa Permanente, an American integrated managed care consortium that is headquartered in Oakland, California. Like I said initially, affiliated multi-specialty, aligned financing, clinical delivery, aligned, despite the fact they have many specialists. They use prepaid coverage, common enterprise, EHR, electronic health record. No fragmentation, minimal fragmentation, unnecessary volume per person or per facility or per specialty, and support population programs. And I also came home to look at collaborations that we have seen work in Nigeria. We missed this in Ogun State. When I was commissioner for it, after Exim Bank came, they wanted land. Abuja didn't give them land for 2 years. When they came, I gave them 3 lands in 1 week. But because when they pulled the number, they saw that they cannot make their money, they went back to beg Abuja. And that is why the hospital is in Abuja, and I don't like it. Because I gave them 3 C of O's in 1 week. But it's a case study for partnership between the banking sector and the health sector. The Afrexim Bank and the London King's College Hospital, they have formed partnership to provide a 300 million facility in Abuja that could do anything that anybody could do anywhere in the world, in Abuja, in Nigeria here. This designed to meet the highest global standard, targeted local research opportunity for us, our teachers, our researchers to work with them. Strategic, now they have formed new partnership after the hospital was inaugurated. They formed strategic partnership with Bank of Industry, in some area of investment, and the Nigerian National Petroleum Corporation. Eco Hospital, we all know Eco Hospital Nigeria, a pioneering example of partnership at individual level. Of course, the 3 doctors, our 3 bosses, our 3 orgas, who showed example on how partnership between medical experts could work. They founded by 3 doctors, Alexander Inelli, Dr. Sonny Kuku, and Dr. Amechi Obiora, since 1982. That hospital functions as a private tertiary teaching hospital in Nigeria, provides range of curative and diagnostic care till today, between 1982 and now. And of course, many branches they have established. They are the first private hospital in Nigeria to be listed in the Nigerian Stock Exchange. So why don't we create a system that allows to also pool public resources within the sector space, so that this 3.7 GDP can grow like other sectors of the economy. We have Duchess International Hospital. We see that advert on TV almost every time. A world-class facility comparable to best globally. The Vice President of Nigeria was operated in that hospital sometimes, offering affordable premium health care, supported by CBN, Access, and maybe some other bank, provide a high standard of care. So this is example of partnership within their sector space, where private sector banks, social investors, and other people have come, and even individuals have come together to provide large-scale service to improve Nigeria. Other examples, whether proposed or whether functional, we have Lagos Medical Park in Ikoyi. I'm sure many of us from Lagos are aware of that. We have Cross River 105 medical facility that IFC facilitated. Alliance is under construction. Muritala Mohammed Specialist Hospital, Kano, Dangote is partnering with that hospital, and they are doing well, I am told. Medix Partners Multi-Specialty Hospital are some examples that we have around, and we could study and improve on how people and partners have worked together to improve the healthcare outcomes. But beyond the supply side, beyond talking about us, workers, building hospital, providing services, we also need to partner with other people who are in other sectors, because there are 2 sides to optimizing and ensuring universal health coverage. There are 2 sides to it. The supply side is that there is a demand side that is equally important. Because of what use is for us to cook a good soup and nobody is willing to eat it. So we must look at supply side strategies. And I've put together here, the demand side strategy. So beyond the supply side, we need demand side partnership. We need partnership from other people, largely outside the health sector, to help achieve universal health coverage. Some of the demand side strategies for healthcare include financial incentive, like conditional cash transfer and vouchers. So we must work with actors that could provide some of these resources, social investors, corporate entities, donors, philanthropists. We must continuously engage them and develop strategies that will put interest in them to support the demand side strategy. Community involvement. Community also have enormous resources that sometimes are misused in areas that will not better their health. So if we pull those resources into functional services, then they join. We have community gatekeepers, women group, youth organization. It will marvel you the enormous amount of money people spend on treatment that will not benefit them. The other demand side strategy I have listed there include enhancing patient transfer and physical access. Here, where you have emergency transport fund, provision of intermediate form of transportation. These are part of the value chain, the health system value chain, that we need to invest in and work together with others that could make us achieve more results. Key actors include transport organizations. We must begin to work with them, big corporate volunteer groups, estate managers, where we need them. And then on information and education, which is very important for service uptake, Because sometimes we even have good quality services. People are not aware they are there. Okay, people don't know that a new hospital has been built, a new specialist is in town. And sometimes we see health as if everybody must know you are here and they must find you out. So we need to work with actors like media organizations, media owners, communication experts, communication companies, MTN of this world, the Airtel of this world, media influencers, and even content creators. The content creators of today can help us send the necessary message that will enlist investors in bringing their resources to their sector space. The key benefit of partnership, without taking much of your time again, has to be about resource, risk, and sharing. We know, I've said that over and over. Innovation, technology transfer, capacity building, access, equity. But more importantly, it's about resilience and sustainability. Our system is just not resilient. You know, many private hospitals fold up after some time. I've seen it over and over again. So that's why I closed mine after 15 years. I deliberately closed it because I don't want it to collapse. Okay, so we have many beautiful hospitals that have existed, but they are not resilient because we do not have enough partnership to make it go the long run. Lessons for partnership on medical services, we have alignment of incentive across stakeholders, standardized care pathway and workflow. We invest in shared system and data, design, governance, and clinical leadership and mixed revenue. But beyond the crossroad, and this is a message for NMA, and this is my message for my colleagues and my mentors here. How should NMA and Nigerian physicians unlock the partnership potential? We must begin to support adaptation of partnership framework, either as a collective or subgroup or as individual. We must begin to understand governance strategy that will support partnership. Okay? Ensure that we create entities led by physicians and to look at financial gaps where we are within our space area of influence and do something about it. We must make sure that there's clear vision, clear mission of what we want to achieve, and decisions clarity will prevent mission drift. Second is financing and payment design. Is that we must begin to look at systems that adopt blended revenue streams. We must adopt systems that we cannot just say, this is it. We must think out of the box. We must be transparent, most importantly, because most investors who bring private resources want to see our books. And if we hide numbers from them, the books don't hide. They will come and they will not. You know, investors are not emotional. They are not like us. They have not been trained to be social workers. But if our books, and the question to ask, and I tell people, I built a 25-bedded hospital in Ijebu without taking a dime from the bank. When we were doing cesarean section for 3,000 naira, 5,000 naira. And I was able to accumulate such capital without taking a loan from the bank and built a 25-bedded hospital in 2020 from zero capital. So what we need to do is to be transparent in our books. And when we are transparent, enormous resources will flow in. And then once the pie becomes big, even your 1% becomes very big. We need to begin to have what we call clear operations and clear pathway, standardized clinical pathways, implement assembly line operations, and then create dedicated services that is known rather than the rule of the thumb. We must have guidelines that state clearly what people should do, when to do it, and how to do it. Workforce, we must understand workforce and task design. We must be able to create a system that will ensure productivity and quality bonuses that does not pay people equally. We must encourage a system that compensates people based on their level of productivity and performance. It is the system that will bring the best out of the providers. We as NMA individuals must leverage information technology data and ensure quality measurement, deploy single EHR, and of course, also ensure that we bring and institutionalize community outreaches and deliberately, include strategies to create demand in our. We also, as NMA, as physicians, must create a system that integrates supply chain, and ensure vertical integration. We need to localize consumables where possible. We have in-house items, supply system, and trusted local supplier to reduce cost. And the moment you do pooled procurement, you're able to leverage economy of scale and reduce cost of your input. But more importantly and finally, as physicians, as leaders, if we want to change the dynamics, we must ensure and emphasize quick wins. We must ensure and emphasize quick wins. And I propose a 90-day roadmap. Make sure that anywhere we find ourselves, any system we are creating, any partnership we are establishing, we are able to, within first 4 weeks, set a physician-led governance system, do a price banding arrangement, and establish few KPIs so that everybody knows what result to expect. Within 2 months of us setting the system up, we need to pilot an assembly line, and see and test our methodology. And in the third month, at least, you must be able to deploy digital technology that will bring, everybody's information quickly and allow people to access information on equal basis. And we are able to have at least a weekly key performance indicator reviews. On the last line, as I step down from this presentation with gratitude to NMA for this privilege, I want us to know that individually we are one drop. Together we are an ocean. Thank you.
If I were on that side, I would have continued clapping my hands for Dr. Babatunde Ekpaye for that thought-provoking, lucid lecture highlighting the challenges, tracing it from the history, and charting a way forward. Thank you so much for that, and we do appreciate you for that. Please, another round of applause. Feel free. Feel free. While the keynote address was going on, we had quite a number of distinguished personalities join us. We've had with us the Oshupari of Owu Kingdom, one of the Owu Kingmakers, High Chief Olushola Adeoye, join us. You're welcome, sir. And then we had joining us, a past chairman of the Nigerian Medical Association in Ogun State and a past national vice president, first vice president of the Nigerian Medical Association, Dr. Rotimi Adeoye. You're welcome, sir. He's very much an elder here with us. And last but definitely not least, we had joining us the Honorable Minister of State for Health of the Federal Republic of Nigeria, Dr. Ishaq Adekunle Salako. In case you turn around and you're unable to cite him, you probably need to elevate your sight. You can do that physically or spiritually and you'll be able to see him. But he's physically here present, that is ably represented by the very brand new Chief Medical Director of the Federal Medical Center, Abeokuta, who indeed is the very first female Chief Medical Director of that institution of repute that trained me. Please welcome Dr. Sarah Ibiemi. You're welcome, Ma, on behalf of SAR. Distinguished ladies and gentlemen, in case you have the program of events with you, please note that, in the words of civil servants, I have been directed that the National Award of the Nigerian Medical Association, significant milestone, of the Nigerian Medical Association. But before I talk about that, please welcome someone who has served Nigeria meritoriously in so many areas, but his name reverberates in the field of medicine for decades until when he eventually left, like they say, this sinful world. I'm sure the name from north to south, east and west is a household name in medical practice. A former Minister of Education, a former Minister of Petroleum, a former distinguished Senator of the Federal Republic of Nigeria, the late Professor Jubril Aminu, gave birth to people of distinguished repute, and here today, sitting in that name, is Rahima Jubril. Let's welcome her, please. And at the right time, we will know why she's here. So please welcome to the microphone once again, the chairman. Okay. So I believe there is an interlude, and I'm told to abort mission. Distinguished ladies and gentlemen, after this particular session, we will be going for the tea break, and then there is an order for it. At this point, please welcome to the microphone to whet our appetite on this award, the chairman of the Nigerian Medical Association, Dr. Idris Omede, FNMA. You're welcome, sir. So he will tell us quite briefly about the awards and, of course, introduce the awardees, at which time the citation of the awardees will be read by my colleagues. You're welcome, sir.
The chairman of this event, Dr. Kokoye, the NMA president, NOC members, past presidents, our chiefs that are here, members of NEC, once more, good morning. This session is for award and honors of distinguished medical and dental practitioners that have rendered service to NMA and to the medical profession, as well as non-doctors who have equally shown love for the profession and the association. Some of the awardees were conferred the honor through the National Executive Council approval, while others, particularly the fellow of the Nigerian Medical Association, passed through NEC and had it approved and ratified by the annual delegates meeting. In that role for today, we have two persons that will be honored with fellow of the Nigerian Medical Association, which is the highest honor that can be bestowed on any doctor, medical or dental, or any Nigerian that NMA field has done contribute heavily, strongly to the association. They were approved in annual delegates meeting of Casina for the FNMA, and today we have for that category Dr. Professor Aikin Osibogu, while at the time the approval was done, Professor Dr. Jubril Aminu was supposed to be one of the awardees. No sooner was the approval done, he was called to glory on 5th of August, 2025. So his award was converted to be a posthumous one. May his soul rest in peace. In the same Katsina, the governor of Kwara State, that is His Excellency Abrazak Abrahman, was to be conferred with Distinguished Service Award. He couldn't make it. And even today, this period, he's unable to make it. But his Commissioner for Health, Dr. Amina Mustafa Ahmed, is here to receive that award on his behalf. At the Katsina NEC, some distinguished doctors were approved for Distinguished Service Award. And we have in that category Dr. Ali Abubakar Gombe, who was the pioneer CMD of Federal Teaching Hospital, Gombe, and one-time Minister of State for Health, the Federal Republic. And also Dr. Mrs. Aishatu Adamu, the CMD of Federal Medical Center, Jalingo, Taraba State. They went through various processes before their nominations was presented by the award committee to NEC. Their CVs were well scrutinized before they were penciled. They were not the only nominees that came, but the award committee did due diligence to the nominations that we had and came out with these names and was duly approved by the NEC and by the delegates. And by the special grace of God, they are here today for the presentation of those awards. Thank you.
Thank you very much. So on that note, thank you very much, sir, for taking us through the process. And I'd like to invite to the stage the President of the Nigerian Medical Association, Professor Bala Muhammad Audu. And as he steps forward, we'll take the first award of the Fellowship of the Nigerian Medical Association. To present this award, I'd like to respectfully invite P4, as we call him, to the podium. Dr. Osaho Enabulele, past President, Nigerian Medical Association, past President, World Medical Association. And as he steps forward, I'd like to invite the recipients of the first award for today, Dr. Professor Akin Oshibogun. And as he steps forward, his citation will be read.
Professor Akinsoya Olaide Oshibogun graduated as a medical doctor from the College of Medicine, University of Lagos, 1980. Obtained his Master of Public Health from Columbia University, New York, 1984. And following a residency training at Lagos University Teaching Hospital, passed necessary examinations and became Fellow of the National Postgraduate Medical College of Nigeria in 1989 and that of the West African College of Physicians in 1994. You'll agree with me that the list is long, but I'll just quickly go to the end. He served as the Chief Medical Director, CEO of the 800-bed Lagos University Teaching Hospital between 2006 and 2014, and as the President of the National Postgraduate Medical College of Nigeria from January 2022 to December 2023. I thought we would appreciate Professor Oshibogun. He enjoys mentoring younger colleagues. He has been honored with the Distinguished Fellowship Award of the National Postgraduate Medical College of Nigeria, among several other professional recognitions and awards.